Pawan, you can make us live.
Recording in progress.
So, hello, hi everyone. Very good evening to all. I'm Dr. Vinay Purohit. I'm a pharmaceutical physician and working as a Deputy General Manager in Medical Affairs team of Lupin Limited. Lupin, which is one among top 6 Indian pharmaceutical organizations. So it gives me immense pleasure to extend to a very warm welcome on behalf of our entire Lupin team in this special webcast series. And today we are going to discuss on changing paradigms in COPD. So this is the third season of COPD Summit, and we are greatly privileged to have among us Professor Peter Barnes as a keynote speaker who is joining us from London. So welcome, Professor. So Professor Peter Barnes is a senior research investigator at the National Heart and Lung Institute and honorary consultant physician at Royal Brompton Hospital, London. He qualified at Cambridge and Oxford universities and was appointed to his present post in 1987. He has published over 1,000 peer-reviewed papers on asthma, COPD, and related topics, and edited over 40 books. He's among the 50 most highly cited researchers in the world and has been the most highly cited clinical scientist in the UK and also most highly cited respiratory researcher in the world over the last 20 years. He was elected as a fellow of the Royal Society in 2007, the first respiratory researcher for over 150 years. He has been a member of important scientific committees globally on the guidelines for asthma, that is the GINA, and COPD, that is the GOLD. He also serves on the editorial board of over 30 journals and is currently an associate editor of CHEST, the Journal of COPD Foundation, respiratory editor of PLOS Medicine, and editor-in-chief of Up-to-Date Pulmonary Diseases. He has given several prestigious lectures, including the Emerson Lecture at the American Thoracic Society, the Sedao Lecture at the European Respiratory Society, and Cronian Lecture at the Royal College of Physicians. He has also received honorary MD degrees from the University of Ferrara in Italy, Athens in Greece, Tampere at Finland, and Leuven at Belgium. He is an emeritus NIHR senior investigator, a master fellow of the American College of Chest Physicians, and a member of the Academic Europea. He was president of the European Respiratory Society 2013 and 14. So he is also involved in multidisciplinary translational research, which integrates basic science with clinical studies, thereby providing novel insights into common airway diseases. So with this introduction, I would like to hand over the session to now Professor Peter Barnes. Over to you, sir.
Well, thank you very much indeed for your introduction, and good evening, everyone who's listening. So what I'm going to talk about is changes in the way that we manage COPD, and I'll just start with my potential conflicts of interest, which are not very relevant in this presentation. You've already had an introduction to me. I'm currently Professor of Thoracic Medicine at the NHLI, which is part of Imperial College in London. So what I'm going to talk about is initially the high burden of COPD and the unmet needs, to discuss the rationale for using LABA-LAMA combinations in COPD and discuss how these combinations should be used in the management of COPD patients combined with other treatments. So I think we all recognize that COPD is now a global epidemic which affects around 350 million patients in the world. So it has a very high prevalence, with about 10% of people over 45 affected. In Western countries, it's now as common in women as in men, reflecting the equal prevalence of cigarette smoking. It's still underdiagnosed, so we think at least half of the cases are not diagnosed because they're not recognized, and that means they don't get treated. It has a very high impact, so it's ranked as the 5th ranked disease in terms of impact on life and is a leading cause of emergency admission to hospital. It's now ranked as the third commonest cause of death in many countries, although in the UK it's now been down, it's gone down to fourth commonest cause of death, because COVID is now the third commonest cause of death. But because it's a chronic disease, it's very expensive, and you can see that it's costing almost $40 billion a year in the USA, but globally has a huge cost, estimated to be $5 trillion a year by the next 10 years. And this makes it more expensive than the management of all cardiovascular diseases and type 2 diabetes, which means that COPD is a very important disease. The prevalence of COPD is increasing, especially in developing countries, and that's because more women are smoking now than was traditionally the case. But an issue overall globally is that populations are living longer, and COPD is a disease of elderly people predominantly, so it means that more people are surviving to develop COPD. It's also linked with poverty, because many factors linked to poverty are increasing the risk of developing COPD. So this is a very important global disease. It's particularly important in India, because it's now the second commonest cause of death, with around 1 million deaths a year, comprising 13% of all deaths. Over half of the COPD patients in India never smoked, and that means other risk factors are important, and particularly air pollution, both outdoor air pollution and indoor air pollution, and exposure to occupational dusts. As in other countries, COPD is underdiagnosed, and spirometry is performed in less than 10% of patients, whereas we regard spirometry as essential for making an accurate diagnosis. The prevalence of COPD in India, measured by the BOLD International Consortium, is something like 7% of the population, so an extremely common disease. And you can see here the risk factors in India. So actually outdoor and indoor air pollution combined are more important than cigarette smoking. Occupational factors are important, and as well as ozone exposure and environmental tobacco smoke. So many risk factors, some of which are more common in women, such as indoor air pollution from biomass smoke, whereas smoking and occupational causes are more of a problem in men. You can see that there are large regional variations in the prevalence of COPD in India, with the highest prevalence measured in Kashmir. And that may be related to the fact there's more indoor air pollution in these northern areas, but you can see that there's a variation across India, with generally worse in the north. Now, this is a slide to show the pathology of peripheral lungs in COPD. And you can see in the right panel, a small airway from a COPD patient is much narrower than a small airway from an age-matched non-COPD patient. And it's narrowed because the airway wall is thickened and also distorted. And this is a result of inflammation that leads to scarring around the airway, fibrosis. So this has been called chronic obstructive bronchiolitis. But the other pathological change that you can see here is that the alveolar attachments to the small airway, which are important for preventing the airway closure, are disrupted as a result of emphysema. And both of these two pathological changes are clearly irreversible. And that means that drugs have relatively little effect on the obstruction of small airways in COPD compared with their effects in asthma. So when normal people breathe out, the airways narrow, but they don't close because of the elastin fibers in the alveolar attachments. And that means that alveolar air can be expelled from the lungs. But in COPD, because of these pathological changes that I showed in the previous slide, it means that on expiration, the airways may close completely. This leads to trapping of air in the alveoli, resulting in hyperinflation of the lung, which can be measured by increased lung volumes, such as the functional residual capacity, which is the resting lung volume. So COPD patients hold their lungs at a higher volume, which is uncomfortable, but this air trapping gets worse on exertion, and this is known as dynamic hyperinflation and leads to the main symptoms of COPD, which are shortness of breath on exertion and reduced exercise tolerance. But we can do something to improve these symptoms in COPD patients by giving long-acting inhaled bronchodilators. And these work by relaxing small airways, and this reduces air trapping, and this subsequently reduces symptoms. And we have two classes of long-acting bronchodilator. Firstly, long-acting muscarinic antagonists, which are anticholinergics, which include tiotropium, but several other LAMAs. And secondly, long-acting beta agonists, which include salmeterol and formoterol, which work twice a day, and more recently, once a day LABAs. So these bronchodilators are useful in COPD because they reduce symptoms. And you can see here the effect of tiotropium on lung function. After 4 weeks of treatment, you can see that there's an improvement in FEV1, and that's something that we commonly measure in the clinic, but it's a small improvement compared with what we see in asthma. But what's striking is a marked reduction in FRC, which means the lungs are deflating because of reduced air trapping. So tiotropium was the first once daily bronchodilator introduced into COPD and is a LAMA, but we now have other LAMAs, for example, glycopyrrolate, which is an old drug that was given previously orally. We first showed that this drug, when given by inhalation, had a long-lasting bronchodilator effect, very similar to the time course of tiotropium. We also have some other LAMAs that are clinically available now. Umeclidinium once a day, revefenacin once a day, which is given by nebulizer, and aclidinium, which is given twice a day. And all of these treatments give a sustained increase in FEV1, which carries over into the next day. And there's a reduction of air trapping, which leads to reduction of symptoms, which improves the quality of life. But something that is seen consistently is that you also see a reduction of exacerbations. And it's thought that this is due to a mechanical effect of bronchodilators preventing airway closure when airways become infected with viral or bacterial infection. So the ways that LAMA work are by interacting with cholinergic tone. So in normal people, there's a certain degree of cholinergic tone, which is the tonic release of acetylcholine from cholinergic nerve endings in the airway, which gives a small degree of bronchoconstriction, which is not perceptible. But in COPD, the same amount of cholinergic tone has a marked effect on airway resistance, because this is inversely proportional to the fourth power of the radius. So when you've got fixed narrowing of the airway, as we've seen in COPD patients, then any further narrowing from cholinergic tone has a very large effect on resistance. So we can block cholinergic tone in two ways: with LAMA, which counteract the effect of acetylcholine on muscarinic receptors, and by LABA, which act as functional antagonists, which are counteracting the bronchoconstrictor effect of acetylcholine. And in COPD, these two bronchodilators have a fairly equal bronchodilator effect. This is not the case in asthma. So in asthma, you have cholinergic tone, but you also have bronchoconstrictor mediators that are mainly released from mast cells. And these include histamine, cysteinyl leukotrienes, and prostaglandin D2. So when you give a LAMA, you only block the cholinergic tone component of bronchoconstriction, which means you have a small bronchodilator effect, as in COPD. But in patients with asthma given a LABA, you have a much greater bronchodilator effect, because the LABA is counteracting every bronchoconstrictor, including all of these mast cell mediators. And because LAMA and LAMA have equal effects in COPD, what it tells us is that the only reversible mechanism in COPD is cholinergic tone. And this is in marked contrast to what we see in asthma. So I mentioned that long-acting bronchodilators reduce exacerbations or prevent exacerbations, which is thought to be a mechanical effect. And this is a study that compared salmeterol twice a day with tiotropium once a day in reducing exacerbations in quite severe COPD patients. And what you can see is that the tiotropium was significantly better at reducing the exacerbations than the LABA. And this was particularly true with severe exacerbations, which are the most important ones that we need to prevent. So it looks like LAMA may be better at LABA in this respect. However, these drugs that were compared have a different duration of action. We now have several once-a-day LABAs. The first of these was indacaterol, and this is a study that compared the standard dose of indacaterol with an equivalent dose of salmeterol twice a day. And you can see that the indacaterol is better in reducing symptoms. It also improves FEV1 more to a greater extent, which leads to a greater benefit on quality of life and symptoms. But this suggests that duration of action is just as important as the type of bronchodilator. And it's clear that once daily bronchodilators are better than twice daily bronchodilators, which are better than 4 times daily bronchodilators that were used previously. And this is irrespective of whether it's a LABA or a LAMA. Now, this is a study that looked at tiotropium once a day compared with formoterol twice a day. And you can see that a once a day drug is better because it gives a better overall improvement in FEV1. Whereas with formoterol, the FEV1 goes back to baseline before the second dose is given. However, what this study also showed is that if you add formoterol to tiotropium, that you get a greater bronchodilator effect. Firstly, you can see an increased peak, but you can also see that the bronchodilator effect is more prolonged. But these drugs are not good in combination because formoterol has to be given twice a day. So you really need to match the duration if you want to put the 2 drugs in the same inhaler. Here is indicaterol given at the highest recommended dose, which is 300 micrograms once a day. But in this study, they actually went to double this dose to see whether 300 was the maximum effect. And it was, because 600 didn't produce any further improvement in FEV1, although it did cause more side effects, which is why we don't use such a high dose. So it looks like that's the maximum possible bronchodilation. And yet, when you add glycopyrrolate, you can see that you more or less double the bronchodilator effect. And that means that you could actually combine these 2 drugs in the same inhaler, which was what was done here in this combination called QVA 149, which is now known as Ultibro. So what you can see here is a marked additive bronchodilator effect, giving an improvement of more than 300 mils in FEV1, which is much greater than we see in any other study using single bronchodilators. And this is something which is carrying on over time. So you can see here that when you give the combination inhaler, you get a greater improvement in lung function even after 6 months of treatment compared with the single inhalers, indicaterol or glycopyrrolate, or with open label tiotropium. So this is clearly of benefit in improving the lung function. But you can also see a greater reduction in symptoms. So the combination here, shown in the red bar, is having a greater effect in reducing symptoms than tiotropium on its own. Similarly, if you look at preventing exacerbations, you can see that the combination in the red bar again gives a greater reduction in exacerbations than the glycopyrrolate or the open label tiotropium. So it has a benefit on all of the actions of the bronchodilators that I've discussed previously. But an additional benefit of long-acting bronchodilators is that you may also improve cardiovascular function. And this is important because 70% of COPD patients are known to have cardiovascular disease. And in fact, cardiovascular disease is the commonest cause of death amongst COPD patients. So here, this combination of indicaterol and glycopyrrolate was given for 2 weeks and then crossed over to placebo. And what you can see is that with the combination, there's a marked reduction in air trapping, as I've shown previously. And this is associated with a marked improvement in cardiac function. And that's because the air trapping and hyperinflation reduce cardiac output. So left ventricular volumes are reduced, and this can therefore improve overall cardiac function, which is commonly impaired in COPD patients, especially with severe disease. So this has led to the development of several fixed-dose LABA-LAMA combination inhalers. There are 3 that can be given once a day. So indicaterol glycopyrrolate, which is the Ultibro inhaler, which I've already discussed. But you also have 2 others, olodaterol and tiotropium, or vilanterol and umeclidinium. And all of these are very similar in their efficacy. There are also some twice daily combinations, all of which use formoterol as the LABA, and use different LAMAs in combination. So these are equally effective, but some patients prefer a once daily compared with a twice daily inhaler. There are some new drugs that are called MABAs, which are muscarinic antagonist, beta agonist drugs. So this is a single molecule that has a LABA at one end linked to a LAMA at the other. And batofenterol and navofenterol are drugs that are currently in clinical trials. But the problem with MABAs is that it's very difficult to balance the LABA and the LAMA effects. For example, batofenterol is mainly a LABA, whereas navofenterol is mainly a LAMA. And what you want is equal effects. So that's better achieved by putting the 2 drugs in the same inhaler. So these combination inhalers give a marked reduction in air trapping, as you've seen, which improves symptoms and quality of life, reduces exacerbations, improves cardiac function, and these combinations are very well tolerated by COPD patients. So GOLD now strongly recommends the use of long-acting bronchodilators. And if you look at the initial pharmacological treatment, you can see that the choice of drug is determined by the clinical features of the patient. And we look at 2 main things in deciding on therapy. Firstly, how bad are the symptoms? And secondly, whether patients have exacerbations. And using those 2 criteria, you can divide patients into 4 groups. So groups A and C are people that have very few symptoms. And these patients are very unlikely to get any treatment because usually they would never get diagnosed in the first place. So almost all of the patients that we see are fitting into group B, which doesn't have exacerbations, or group D, which has symptoms plus exacerbations. And around 30% of patients fit into group D and 70% into group B. So what this shows is that inhaled long-acting bronchodilators are the mainstay of treatment indicated for group B and group D patients. And this could be a LAMA or a LAMA and a LABA in combination. Personally, I prefer to start with the combination to give maximal bronchodilation from the beginning. But you can see in group D, another option is that you could give ICS, inhaled steroid LABA combinations. And we know that this is something we can do in particular patients. So we know that inhaled steroids are not very effective overall in COPD, but they do have some clinical benefits. And this is a meta-analysis of studies that compared inhaled steroids with placebo in COPD patients. And what you can see is that overall, there's around 20% reduction in exacerbations with inhaled steroid, and this is consistent between different studies. So across different studies, ICS reduce exacerbations by about 15 to 20%, but there's little or no effect on lung function, on symptoms or quality of life. There's no effect on mortality, either all-cause mortality or respiratory mortality, and no effect on disease progression, which is measured by FEV1 decline over 3 years. So the only clinical indication to use inhaled steroids is to reduce exacerbations. So they're not really a treatment that would be considered for the group B patients, only for the group D patients that have exacerbations. And yet, if you look at prescriptions in the real world, you can see that the treatment with inhaled steroids is given to patients in every group, including group A, where the patient has almost no symptoms, and group C, which we hardly ever see, but is used also in a high proportion of people in group B, as well as a very high proportion in group D, where they may be indicated. So this is a very high use of inhaled steroids, which now goes against the recommendations that we make. So as I showed you, inhaled steroids reduce exacerbations. So what happens if we compare two combinations? So one combination had ICS LABA, and that is the serotype combination, and that was compared with indacaterol glycopyrrolate, which you can see had a greater reduction in exacerbations. So despite the fact that inhaled steroids reduce exacerbation, giving two bronchodilators has a greater effect. And this was irrespective of the sex, ethnic group, smoking status, severity of disease, or previous treatment with inhaled steroids. And that may be because many people with COPD don't benefit from inhaled steroids, which is why the LABA-LAMA combination is more effective. And what we now recognize is that blood eosinophil counts are very good predictors of which COPD patients may respond to inhaled steroids. And blood eosinophil counts are very easy to do in clinical practice because it's part of the routine blood count that every general practitioner can do, at least in the UK. So this is a study looking at how blood eosinophils will predict or affects the effect of steroids in reducing acute exacerbations. And you can see that as blood eosinophils increase, then the reduction in exacerbations compared with the LABA alone gets greater. So blood eosinophils are related to exacerbation risk, and adding budesonide reduces exacerbations overall by around 25%. And the cutoff point that we now take is 300 eosinophils per microliter, because below that you don't get enough benefit from adding the inhaled steroids, whereas above that you can see inhaled steroids clearly have a greater effect in reducing exacerbations than in the other patients. And the reason why we don't give inhaled steroids to everyone is that high-dose inhaled steroids have side effects, and particularly long-term side effects, which may not be apparent in short-term clinical studies. Firstly, maximal doses are usually used in COPD because steroids are not very effective. You may have local side effects, and particularly common is hoarseness of the voice. There's a high risk of osteoporosis and fractures, and we already know that COPD patients are at risk from osteoporosis because they're elderly patients with low mobility and poor nutrition, and they may smoke, which are all risk factors for osteoporosis. There's an increased risk of cataract formation, and comorbidities may be worsened, particularly type 2 diabetes. And many patients with COPD that are started on inhaled steroids may develop type 2 diabetes because it's a very common comorbidity of COPD, but also hypertension and peptic ulceration may be made worse. And what many people have focused on is an increased risk of infection. And that includes tuberculosis, which may be reactivated, or non-mycobacterial lung disease. But I think most attention is focused on the increased risk of pneumonia with inhaled steroids. And this was shown first most clearly with the TORCH study. And this really only could show it because they had a very large number of patients studied over a long time period. And what you can see in this study, which had around 6,000 patients studied over 3 years, was that the two treatment groups that had inhaled steroids, so either fluticasone alone or salmeterol fluticasone combination, you can see that there was a cumulative increase in pneumonias. These were doctor-reported pneumonias, but this observation has been confirmed since with radiologically diagnosed pneumonias. So we know that it's a true increase in pneumonias. Now, the point of giving the inhaled steroid is to reduce exacerbations. So the number needed to treat to prevent one exacerbation is 44, but the number needed to treat, the number treated to induce one pneumonia is only 16. So this is a very poor cost-benefit ratio for inhaled steroids. And that's why we shouldn't give inhaled steroids to everyone with COPD, but we should only select the patients who are going to benefit. And that's because of the risk of side effects. And this increased pneumonia is confirmed in community studies. So in this Canadian study, it was found that people who were with COPD who were treated with inhaled steroids had more frequent pneumonias. And this was dose related. So higher doses had a greater risk than lower doses, but it was also related to the steroid. So fluticasone appears to have a much greater risk of pneumonia than budesonide. I'll come to the reasons for that soon. So blood eosinophils are important for selecting which patients can benefit from inhaled steroids, but they're also useful for telling us that which people are more at risk of getting pneumonia with inhaled steroids. So this is another post hoc analysis which looked at inhaled steroids versus non-inhaled steroid treatment. And what you can see is that the probability of pneumonia is increased with inhaled steroids, as all of the studies have shown, but is 50% greater in the patients that are treated, that have a low blood eosinophils, less than 2%. So that's why we don't want to give inhaled steroids for those patients, because not only do they have less effect in reducing exacerbations, but they have an increased risk in causing pneumonia. So that means we should be withdrawing inhaled steroids in many of our patients who are currently treated with them. This was the first study that looked at what happened when you reduce inhaled steroids, and the patients in this study were switched from fluticasone salmeterol twice a day, or seretide twice a day, to indacaterol once a day. And they were measuring time to the first exacerbation. And you can see there was no difference. So taking away the steroid, the fluticasone, didn't lead to an increase in exacerbations. But these patients were in GOLD group B, so they had a very low risk of exacerbations. So you wouldn't expect necessarily that they would develop an increase. But this study is much more important in that respect, because this is looking at people with severe COPD who are treated with a LAMA and ICS LABA combination. So they're on triple therapy, and they had a history of exacerbations. And you can see that when ICS was withdrawn over about 3 months, that there was no increase in exacerbation, even in these high-risk patients. However, blood eosinophils can predict if exacerbations may occur after reducing inhaled steroids. So if they only have one exacerbation in the previous year, it's the blood eosinophil count, even high blood eosinophil counts don't matter, because you still don't get exacerbations. However, if you have a history of 2 or more exacerbations in the previous year, then the patients with high blood eosinophils, you can see here more than 300 and more than 400 cells per microliter, do have some increased risk of pneumonia. So you should not withdraw inhaled steroids if the patients have frequent exacerbations and they have increased blood eosinophils. And that led to another study where the blood eosinophil counts were stratified. So these are patients who reduced from triple therapy to dual bronchodilator therapy. And you can see that if their blood eosinophils were less than 300, then there was no increase in exacerbations. And this comprises about 76% of the population. Whereas the 24% that had increased blood eosinophils, you can see did have some increased risk of exacerbation when the inhaled steroid was withdrawn. So this really confirms the previous analysis of the Wisdom study. So blood eosinophils are a very important biomarker of which patients are benefiting and which patients are not benefiting and may even be harmed by ICS. So in GOLD, it also gives advice about what to do after initiating therapies if patients continue to have problems. And here you can see the patients may be on LABA or LAMA, or they may be on ICS LABA. But if they continue to have symptoms, then if they're on a single bronchodilator, you switch them to a dual bronchodilator because of the additive effects. If they're on ICS LABA, And you may you may put them on to triple therapy by adding the other bronchodilator. But if the blood eosinophils are less than 300, the ICS may not be doing any good. So the ICS LABA should switch to LABA-LAMA, and the triple treatment should be de-escalated to LABA-LAMA because they don't need the steroid. So that's fairly straightforward. It's more complicated if they continue to have exacerbations. So these are people in gold D category. And if they're on a LABA or LAMA, again, you add a LAMA, or a LABA, so you have dual bronchodilator. But if the eosinophils are above 300, then you may add an inhaled steroid. And then if the eosinophils are above 300 and they still have exacerbations after LABA-LAMA, you then add the inhaled steroid, and so they go to triple treatment. But if the eosinophils are less than 300, the steroid needs to be withdrawn, so you're back down to dual bronchodilators. And if they continue to have exacerbations despite triple therapy, you may consider adding another class of drug. So either a phosphodiesterase 4 inhibitor, roflumilast. This is indicated in people with severe COPD that have chronic bronchitis, but is very poorly effective and has very frequent side effects. So we have very few patients who will continue to take roflumilast. The other treatment is a macrolide antibiotic such as azithromycin, which seems to reduce exacerbations specifically in ex-smokers. It doesn't have any effect in continuing smokers. So if we look at inhaled steroids in COPD, there's strong support for using these drugs if there's a history of hospitalization, if they have 2 or more moderate acute exacerbations a year, if blood eosinophils are more than 300 per microliter, and if there's a history of concomitant asthma, which is asthma COPD overlap, which we think is more likely to be the fact that asthma and COPD may occur together in the same person. There's strong support against the use of inhaled steroids in people who've had previous pneumonias, in people who have low blood eosinophils, or people with a history of tuberculosis, which is an important factor in India. And then there's an intermediate group where we're not quite certain, and those are people who've had only 1 moderate exacerbation in the previous year, or who have blood eosinophils in the intermediate level between 100 and 300. And inhaled steroids may be useful in these and may or may not be useful. So those patients that benefit from inhaled steroids could be switched from ICS, LABA, and combination with tiotropium or other LAMA to a fixed triple combination. And this is the first fixed triple combination that was developed that has BDP, formoterol, and glycopyrrolate in the same inhaler. And this was compared in this study with the BDP formoterol fixed dose inhaler. And as you would expect, the FEV1 is greater after triple because you're then giving 2 bronchodilators. But you also see some reduction in exacerbation with the triple compared with the ICS LABA. And this has led to the development of other triple inhalers. So there are now 4 fixed dose triple inhalers that have been approved in Europe and probably most places in the world. And these are given either twice a day, like Trimbo and Breztri, or they're given once a day, like Trelegy and Enazare. So this is a triple combination that has fluticasone furoate, a once-a-day steroid, with vilanterol and umeclidinium, and that's compared with ICS-LABA and LABA-LAMA. And you can see that overall, the triple, which is the blue line, has less exacerbations than the other treatments, including the LABA-LAMA. But this study is difficult to interpret because the difference is seen in the first month, and then the lines are parallel. And most of the patients who entered this trial were already on inhaled steroids. So it means that the ones switched to placebo and LABA-LAMA actually had steroid withdrawal. So some of them may have got worse in terms of increased exacerbation. But the other thing about this study is that the people treated with pneumonia, with inhaled steroids, either ICS, LABA, or triple, had a 50% increased risk of pneumonia. Another large study looked at a twice-a-day triple with budesonide, glycopyrrolate, and formoterol, known as Breztri, and looked at reduction of exacerbations. And in this study, there were 4 treatments. But what you can see is that the triple combination was given in 2 doses, with a lower and a higher dose of budesonide. And both of these reduced exacerbations more than the LABA-LAMA or the ICS-LABA. So similar results to the previous study. What this study found is that there was a reduction in mortality. And it turned out that this was explained entirely by a reduction in cardiovascular mortality. And this was also seen in the previous study that I showed in the last slide, the IMPACT study. So it may be that there's an effect of inhaled steroids in reducing cardiovascular mortality, but these studies were not powered to look at this because they had very few deaths and only studied the treatment over a 1-year treatment period. So longer studies are now in progress to explore whether there's any reduction in mortality. So in conclusion, overall, long-acting bronchodilators are the most effective treatments that we now have for COPD. LABA and LAMA have additive bronchodilator effects, which provides a very strong rationale for combining them in the same inhaler device. And these LABA-LAMA combinations reduce symptoms, improve quality of life, reduce exacerbations, and also improve impaired cardiac function. Inhaled steroids only reduce exacerbations. They have no effect on symptoms, mortality, or disease progression. And they're more effective in reducing exacerbations in the people with blood eosinophils more than 300 cells per microliter. So we can withdraw inhaled steroids in patients with eosinophils less than 300 per microliter who have infrequent exacerbations. LABA-LAMA combination is the preferred therapy for reducing symptoms and for reducing exacerbations unless people have a high blood eosinophil count. And so LABA-LAMA combinations should be considered as first-line therapy for all patients with COPD who require treatment. And this is a very important change in the way that we manage COPD. So thank you very much for your attention, and let me stop sharing.
So thank you so much, Professor Peter, for this enlightening talk And now we have among us Dr. Rajadha, who would be moderating the questions which we have received during your session from our live audience. So Dr. Rajadha doesn't need any introduction. He's one among the most senior and reputed pulmonary medicine expert from India. Currently, he's director and head of Department Pulmonology in Fortis Hospital, Kolkata, and also director for research and education, National Allergy Asthma Bronchitis Institute. He has been the chair for training and educational initiatives for Indian Chest Society, governing body member of the Indian Chest Society, Indian Academy of Bronchology, joint secretary for Indian Academy of Allergy, and also important, the founder member of Southeast Asian Academy of Sleep Medicine. He has more than 124 international and national publications in Index Journal and abstracts along with 12 book chapters, and abstract reviewer for American College of Chest Physicians meeting, American Thoracic Society meeting, and European Respiratory Society 2012 till date. He has been a routine examiner for the MRCP both in UK as well as in India. So, Dr. Rajadha, over to you, sir.
Thank you, Vinay. Professor Barnes, this is a fan moment for me. You know, I've listened to a few hundred of your lectures, and I have listened to one after quite a long time because of the pandemic, maybe. So it gives me great pleasure to be able to speak to you on a platform and discuss a few of my own questions and some questions which have come in from the audience. So we'll do that over the next 20 minutes. And I would like to thank Lupin for providing me with this opportunity to speak to you. So I'll ask you some clinical questions, Professor Barnes, some which are probably relevant to our practice in India, but also generally in the practice of respiratory medicine. So in the initial part, when you spoke about lamas, you spoke about the choice of a lama. And you sort of spoke about tiotropium and glycopyrronium, which are the lamas which are available currently in India. And there'll be more in the not so distant future. So how would you actually choose between the two main lamas that are available to us? How would you prioritize? Do you have a phenotype of COPD patients where you would use one over the other? So you're sort of thinking between these two.
Well, I think they're very similar. I showed you the time course, which is very similar. So glycopyrrolate, I mean, let me just first of all say glycopyrronium is a word that the pharmaceutical company used for glycopyrrolate. So pharmacologically, we should call it glycopyrrolate, which is an old drug. And I think they were trying to show it was a different drug from glycopyrrolate, but it's the same as glycopyrrolate. Glycopyrrolate's been around for a very long time as a tablet and was used by anesthetists to dry up salivary secretions before general anesthesia. And we studied it because it was one of the few anticholinergics available. And we showed that it had a very long time of binding to muscarinic receptors in human lung, which was very similar to the binding of tiotropium. So we then did a clinical study where we nebulized glycopyrrolate and showed that it had a very similar time course of bronchodilation to tiotropium. And so we asked Imperial College if we could patent this, and they said, there's no point because it's an old drug. So you might as well publish the paper, which we did. And a Japanese company saw the publication and then produced it as a dry powder, which they sold to Novartis for $1 billion, which could have been ours. But I think these are very similar in terms of their duration with the dose. If you give a low dose, which they do in the US, then you have to give it twice a day. But if you use the dose that we can use here, it's effective as once a day. So it doesn't really matter which one you choose, they're equally effective. Oh. And umeclidinium is another once a day, which is equally effective. But aclidinium is equally effective, but needs to be given twice a day. It doesn't have such a long duration. Sure. But I think they all work in the same way because they're all blocking the muscarinic receptors.
Sure. And so I understand about the efficacy part, Prof, but anything about the side effect profile? You think they're exactly the similar?
Yeah, side effect
in the way they work?
Profile is very similar. I mean, side effects are not a big problem with llamas. I mean, the side effect that's commonest is dryness of the mouth. But we found that tends to disappear if patients continue using the treatment. And I don't think any patients ever stop the treatment because of a dry mouth. The other possible side effects, which are quite uncommon, are glaucoma, which may come from the spray going into the eye, or maybe from systemic absorption, and urinary retention. So if patients have a history of urinary retention or they have glaucoma, then we have to be quite careful.
Sure.
And certainly with glaucoma, to make sure that the inhaler doesn't go into the eye, which is not a problem with dry powder inhalers because they're not going to have a spray.
Yeah, sure. So, Prof, in similar lines, you spoke about once a day. You've just spoken about once a day and said once a day of glycopyrronium is fine. We have seen some data in India, and this is just not a question from me, it's also Dr. Satish from Pune who asked this question. So there is some data that patients who have nocturnal symptoms in COPD could do better with twice a day of the glycopyrronium as opposed to giving it once a day.
Yeah.
Any thoughts there?
It's a good point. And tiotropium has been looked at, given in the morning versus given in the evening, and there was no real difference. And I think because it has a sustained effect, then it's fine to give it once a day, because the next morning when you take the next dose, the lung function is already improved. It doesn't go back to baseline. In the initial studies that we did with tiotropium, we found that it lasted for 72 hours in some people. So there's a big carryover effect.
Sure.
And that's why once a day drugs are generally better. But I mean, with twice a day, you probably get similar efficacy, but it's certainly not greater efficacy, but it's not significantly less. But some people like taking their drugs twice a day. They feel more secure, whereas other people find it more convenient just to take the treatment once a day. And it doesn't matter if they take it in the evening or in the morning. I think they are equally effective.
Sure. But sort of as answer to my question, Prof, if you had someone who is on once a day glycopyrronium and we found that the patient was having nocturnal symptoms, you would rather step up on the treatment rather than thinking about giving it twice a day, splitting the dose and giving it twice a day. Is that sort of the carry home message for the audience?
Well, I think what I would do is add a LAMA at that point, because if they're still having symptoms, that they need more bronchodilation. And I think if you give another bronchodilation, it as you saw with the formoterol study with tiotropium, you actually prolong the effect as well as increasing the peak. So it sort of makes it longer acting as well.
Sure. Prof, another quick comment. This is very relevant to our country. You know, you spoke about revefenacin and the fact that it's nebulized.
Yeah.
There's a lot of people in India, and I guess across the US, who believe on nebulized drugs in patients with COPD. And there's various reasons. Some say there's not enough inspiratory flow to take up DPI or an MDI. Some people would say that post an exacerbation, when they're going home, you would give them the nebulized drug. And of course, there's the tremor and the arthritis and so on about triggering an inhaler. So where would you position nebulized now? Not specifically revefenacin, but in an ICS, LABA, and the LABA is available in India now as nebulized drug. How would you position it? What percentage of your patients, and where would you think you would prioritize it over an inhaled therapy? I mean, as an inhaler therapy.
Yeah, no, that's very good questions. I mean, some patients like nebulizers because when they go to hospital, they get nebulizers and they feel they're stronger. And it's sort of, they can take the nebulizer with tidal breathing. But we prefer not to use nebulizers because they may become over-reliant on them and not seek medical attention. Also, they're more expensive as a way of delivering drugs. They can get infected. So there are various issues. They're not portable, which is not really an issue with once-a-day drugs. But in general, we have very few patients who have home nebulizers.
Sure.
With tiotropium, as you know, it's available as a dry powder inhaler, which was the initial formulation, but is now available as a soft mist inhaler. And that's a sort of mini nebulizer. So it's giving a soft mist, which patients may find easier to use. And in our department, Omar Osmani compared tiotropium via the dry powder with tiotropium given by the soft mist, the Respimat, and found that he got a better clinical effect with the soft mist inhaler, especially measuring small airway function. So that inhaler may give you better peripheral distribution. But as for nebulizers, I don't think most patients really need them at home.
Okay, grand. So I'll move on. A couple of last questions about bronchodilators. So I wanted to ask you about, you spoke about LAMA being superior to a LABA when you are giving a single inhaler, and you mentioned the POET study. There's other studies which have shown that the LAMA is superior to a LABA. But you also spoke about sort of 30% of patients being Gold D, 70% of patients being Gold B. Maybe the Gold D population in India is slightly greater than that, but I mean, it's in the B and D bracket.
Yeah.
Do you still feel there's a place for a single bronchodilator anymore, or do you think it's always going to be dual, so this comparison does not really matter?
Yeah, so I don't think there's really, I mean, my interpretation of the POET study and the other studies showing that tiotropium was better is because it has this sustained bronchodilator effect. I don't think it's because an anticholinergic is better than a beta agonist, because the beta agonist really, if you match the duration, so indicaterol versus glycopyrrolate, it has very similar bronchodilator effect if you match for the duration. So that's why I think these combination inhalers work so well, is because you've got matched duration of drug effect and it carries over. That's the important thing. So the next morning, the patients still have the effect of the bronchodilators taken the previous morning, and then they top it up with another dose.
Yeah. So, Prof, would it be fair to say that in our practice, the practice that we do in respiratory medicine or as a physician looking at COPD patients, the role of a single bronchodilator would be very small currently? It's mainly going to be dual bronchodilation as the way forward?
Well, I think if you're a specialist, you're going to be probably seeing the more severe patients, the moderate to severe patients. So you're probably going to have people that need dual bronchodilation, because otherwise they wouldn't go to see a specialist. So GPs may start people on one inhaler, and what we recommend is to start with a LAMA. And in the UK, I think GPs don't do that. They start with ICS LABA because they're so used to giving that to people with asthma, and they treat COPD as if it was asthma that's rather severe, and then they add a LAMA later. Whereas we think that a LAMA is better than ICS LABA, and they should start with that, or they could start with dual bronchodilator inhaler. I think there's some theoretical advantage to giving ICS LABA combination from the beginning, and that's because you reduce mechanical stress in the airways by dilating them more, and that may reduce fibrosis, which may reduce disease progression. And in the study, the very large study that was done with tiotropium over 4 years, they looked at disease progression and found that in the gold 2 patients, that the tiotropium did significantly reduce disease progression. So, I mean, we don't know the mechanism, but we speculate that it may be a mechanical effect of a long-acting bronchodilator.
Yes.
So that's a theoretical benefit, because it hasn't been shown in a controlled trial that you do reduce progression. This was a post-hoc analysis, but there are theoretical reasons why it may. So my view is you want maximum bronchodilation from as soon as you can, because you may possibly improve progression of disease.
Sure. Grand. So I'm relieved to know that even in the UK, you've got GPs who are prescribing an ICS and a LABA. I mean, that's the practice in India with most GPs and physicians.
Yeah, that's because they know it from asthma. That's the reason.
Yeah, sure. Sure.
But I think it's important just to emphasize that COPD is very different from asthma.
Sure.
And some people have tried to make the case that they're all one disease, with asthma at one end of the spectrum and COPD at another, and then ACO is the people in between. But this is nonsense. These are very different diseases, and they both have airway obstruction, because there's not much that the airway can do other than obstruct. And they have a different pathology, different risk factors, different progression, different symptoms, and they need to be treated differently.
Sure. Prof, there's another concern about combining a LABA and a LAMA, I think across the world, but definitely in India, which is about safety profile. So there's a question from Dr. Shanmugam Puja from Chennai, and she asks about cardiac and pregnant patients. However, I mean, I know there's not much of data because these patients, the pregnant women, actually got excluded from studies. But from a cardiac toxicity perspective, do you think adding the LABA and LAMA actually has a risk, especially in patients who've got cardiac
in pregnant patients? Because you're not going to have many of those that have COPD. So probably not many studies have been done with LABA. We know that budesonide is safe in pregnant women. We don't know much about LABAs and LAMAs. I think formoterol is safe in pregnant women, but I mean, these are studies that were done in asthmatics, not in COPD.
Sure.
So I don't think it's an issue in COPD management.
And cardiac, you be sort of reassured about giving the combination in even patients with cardiac comorbidities, Prof?
Well, I think there's no evidence that either LABA or LAMA are dangerous in people with cardiac disease. There was some concern that LAMA may increase arrhythmias because it may increase heart rate, but that's in very large safety studies that's specifically undertaken to check the safety. There was no evidence of any cardiovascular risk with LAMA, and I don't think there's any risk of LABA. There was a large study called Summit that looked at LAMA over three years, I think, and there was no cardiovascular risk. And that was in a group of patients that already had cardiovascular risk factors and cardiovascular disease. So they were a susceptible population. So I think we can say these are very safe treatments, even with cardiovascular disease.
Sure. Let me come to the ICS story now, and we'll finish in the next 5 to 7 minutes, Prof. So, so let's ask you a general question first. Your data, Sandeep's data, Dr. Salvi's data, about the non-smoking COPD population. So the one with biomass exposure, the one with traffic exhaust COPD and so on, we know might be a more chronic bronchitic population, they might have a more eosinophilic airway. So do you think, generally speaking, the exacerbating population of COPD, the Goldie population of COPD in India, which is probably larger, would actually benefit more from an inhaled corticosteroid as compared to what it is in Europe or the other parts of the Western world?
Well, that's a very good question, and it's shocking that we don't have an answer, because almost all of the trials were done in people who smoke, because that's how they were defining COPD. So they left out the people who were non-smokers with COPD. And there's very little information about the effect of COPD therapies in non-smoking patients. Sundi Salvi and our group did a study of patients with non-smoking COPD in rural villages near Pune. And we looked at a number of things like symptoms, lung function, CT scans, inflammation in the sputum, and we could see no real difference in the inflammation or the clinical features. The only difference was that there was less emphysema in non-smoking COPD, so they're mainly small airway disease. I think the chronic bronchitis incidence was quite similar. So you do see they have less emphysema, but they're mainly small airway disease. We did a trial of oral steroids to see if there was a difference in steroid responsiveness, as you mentioned about the possibility that steroids might work better with chronic bronchitis. And we couldn't see any difference between, in fact, there was no response to oral steroids in the non-smoking or the smoking COPD patients. The eosinophil counts, I think, tended to be higher in India, but that was true in the controls as well. So that doesn't really help. So the cigarette smokers and the non-cigarette smoked COPD had similar eosinophil counts that tended to be higher, but we didn't see any response to oral steroids, but we haven't looked at inhaled steroids.
Sure. Okay. And sort of continuing with the inhaled corticosteroids story, Prof, you spoke about ethos and you spoke about impact. I know of 2 other studies, and I'm sure you know many more. So Tribute, Trilogy, a whole host of studies which are now looking at the triple. And some of these are patients who belong to Gold B. So I loved your message about LABA LAMA being the choice of treatment in COPD, but do you think there's a slight shift now to going towards the triple as we're going forward? Or do you think this is just a passing phase and the data isn't robust as yet?
Yeah, well, I think people need to do more studies, because, I mean, that's why they have this orange zone between the red and the green for inhaled steroids, which includes the one that have had one moderate exacerbation in the last year. And it may be that's good, but if the only thing the inhaled steroids do is to reduce exacerbations and you don't have any exacerbations, there's not much point to give it, unless it could be shown that it has a clear-cut reduction in mortality. But we don't have such evidence yet, because the mortality reduction that I showed for the ethos and impact trials are really uncertain. I mean, they were not powered to show that, but they both did have less people who died. But I don't think that's sufficient to make a recommendation to add ICS in the Gold B group. So taking all this together, it seems to me that only about 10% of patients with COPD should be taking an inhaled steroid, not the 90% that are currently taking inhaled steroids. So that's a big change. And the good thing is that we know it's safe to reduce or to stop inhaled steroids in the patients that have low eosinophils. So as you saw in one of those studies, 75% of COPD patients have blood eosinophils less than 300. So you're talking about only thinking about them in people with more than 300 who have exacerbations. And that'll be about 10%.
Yeah. Okay. There's another question in the question box from Dr. Ajaz Mohammed. So I'll sort of amplify his thoughts with mine and present it to you. So you spoke about the adverse effect of inhaled corticosteroids. You also spoke about diabetes. Now we are the diabetes capital of the world. So he asks about a patient with diabetes and hypertension who is in an inhaled corticosteroid. Would you be keener to actually withdraw the inhaled corticosteroid in this group of patients if they happen to be on an ICS plus a LABA or a triple therapy? And I mean, how would you sort of weigh the risks of exacerbation if you're withdrawing the steroids versus the risk of worsening the diabetes and the hypertension in this group of patients?
Well, I think it's all a question of balance, and this is where you really have to look at the individual patient. I mean, if they've already been on an inhaled steroid for a long time and they don't have diabetes, then you don't. I mean, there would be less concern about that, or if they had hypertension that hadn't got worse. So you'd have to judge the impact of the comorbidity versus the need to reduce exacerbations. And you should certainly think about LABA-LAMA and not having a steroid if they're getting exacerbations with ICS-LABA, because we know that combination further reduces exacerbations compared with the single bronchodilator. But for each patient, you would just have to weigh up the significance of these comorbidities. It's always a balance between making something worse. And so if they had really bad diabetes that was difficult to control, I think that would be a very strong argument against inhaled steroids unless there was very clear benefit. Of course, it's extremely difficult to judge whether any treatment reduces exacerbations in an individual patient, because exacerbations are random events. And so you can't really measure it very easily in clinical practice. We're looking at group data from multiple patients that are meaned in these trials. And many of the patients will not have an exacerbation in those trials.
Sure. So, Prof, I'll ask you a daft question, a simplistic but a daft question. Do you think low-dose inhaled steroids, when I say low-dose inhaled steroids, say 400 to 800 micrograms of inhaled budesonide, do you think that could alter diabetic control in individuals who are not taking oral steroids at all? Do you think there's data to support that?
Well, I think that there are data to support it. In the ethos study, they looked at 2 doses of budesonide in the triple combination, and they were equally effective at reducing exacerbations, but only the high dose was linked to this reduction of mortality, which is uncertain. So it depends what your endpoint is going to be. It looks like for reducing exacerbations, you don't need to give very high doses. And there are some other studies that show that. But the registration dose in the UK for COPD is always the high dose. And I believe that we don't need to give the high dose because that has a risk of these side effects and infection. So you can probably achieve it with a low dose. The other thing is that you have to think about the choice of steroid. And we know that fluticasone propionate and fluticasone furoate both increase pneumonia in COPD to a much greater extent than budesonide. So we would favor the use of budesonide over fluticasone just because it's a safer steroid. Mometasone should be similar to budesonide because it's not retained in the lung. So the reason that fluticasone is linked to more pneumonia is that it's retained in the lung for longer. And in the patients who have bacterial colonization, that seems to increase the bacterial load and so make them more prone to get pneumonia. So probably we should avoid fluticasone.
Sure. Okay. So, Prof, few drugs that I'll mention, a sort of brief comment about the molecule. So one from my side, I noticed that you spoke about the exacerbation reducing strategies in Gold D. One drug that you did not speak about was N-acetylcysteine. Do you think the data is not robust enough for NAC? Or
yeah, the evidence of mucolytics and N-acetylcysteine in particular is very mixed. I mean, there is a reduction in exacerbations shown in some studies and meta-analyses. So there may be some benefit in that respect, but other studies have shown that you don't have any benefit if you're taking inhaled steroids. So it's very uncertain. We don't routinely recommend N-acetylcysteine because the evidence is not clear enough that it consistently reduces exacerbations. But some patients like it because it helps them bring up sputum. So I think it's something that's an optional treatment, but there's not much good evidence that it has objective benefit. But some patients find it helps them.
Sure. So meeting in India, you would never get away without speaking about theophylline. So there's a question about oral and there's a question about inhaled theophylline. So the oral theophylline, I think there's been a recent study, a big study, which has shown that it's of no benefit at all in patients with COPD, even at a low dose. I am not aware about, Dr. Bikram Singh asks about inhaled theophylline as a future anti-inflammatory drug. I'm not aware of any study looking at this. I don't know whether you know about any study with inhaled theophylline, Prof? Any trials?
Yes, there are some studies that were done a long time ago with inhaled theophylline, and basically they showed that there's no advantage to giving it by inhalation because you absorb it into the circulation. And if you measure bronchodilation, the bronchodilator effect with inhaled theophylline is related to the blood concentration of theophylline. So there's no advantage, and it's actually quite irritant in the lungs. But theophylline itself, we were quite optimistic that low-dose theophylline might be a useful treatment in COPD because we'd shown in our molecular studies that it reversed steroid resistance. So I was involved in 2 large studies of low-dose theophylline in COPD. One was done in the UK, and the theophylline was added to ICS LABA. And what we were hoping to see is a big improvement in symptoms and reduce exacerbations because we would make the ICS more effective. But in fact, we didn't see any clinical difference in exacerbations, except that hospitalizations were less with theophylline. So maybe for very severe people or very severe exacerbations, it has some effect. The second study was done in China, and this was comparing low-dose oral theophylline with low-dose oral steroid and giving them together in combination. And basically, we couldn't show any effect of the low-dose theophylline compared with the oral steroid and theophylline. So we didn't see any benefit there. And it's disappointing because it's a very inexpensive treatment that's widely available. So based on those 2 big studies, it's not possible to routinely recommend theophylline. But it's something always to consider in very severe patients that have had severe hospitalization. You may consider to add low-dose theophylline, which is well tolerated. Compared with the previous way we used to give theophylline. So it's something that should be considered in my view, but it's not included in GOLD as a recommended treatment.
Sure. And the last, Prof, this is a question from Dr. Bikram Singh again about the dual PDE3, PDE4 inhibitor, ensifentrine.
Yeah, ensifentrine is a very interesting drug that's been around for a long time. It's basically an inhaled PDE3 inhibitor. It has almost no effect on PDE4. It's 300 times more potent inhibiting PDE3 than 4, although they call it a combined 3/4 inhibitor. So blocking PDE3 causes bronchodilation. It relaxes human airway smooth muscle. And if ensifentrine is given by inhalation, either by nebulizer, dry powder, or meter dose inhaler, it gives bronchodilation, which is very similar to what you see with a LABA or a LAMA. It has an additive effect with a LAMA and with a LABA, but they refuse to do the critical experiment, which is adding it to a LABA plus a LAMA, because they know it's not going to work. And that's why they don't want to do it, because they're trying to sell it to other pharmaceutical companies. They also claim it has anti-inflammatory effects, which is nonsense. It's theoretical that it would be through PDE4 inhibition like roflumilast, but there's not enough PDE4 inhibition to have any anti-inflammatory effect. And no anti-inflammatory effects have ever been demonstrated in COPD patients. So it's just another bronchodilator. But I think one concern is that PDE3 inhibitors are potentially dangerous because they increase cardiac arrhythmias.
Right.
And in one study where PDE3 inhibitors were given to people in cardiac failure, it increased mortality. So the drug regulators are very concerned about giving PDE3 inhibitors to people who have a risk of cardiovascular disease.
Sure. Thank you, Prof. My last question to you, Prof, and I think this is a relevant last question. So there's a question from Dr. Mahesh Kumar, who asks about non-pharmacological measures in patients with non-smoking COPD. So in my book, I don't think there's anything specific for non-smoking COPD, but maybe a very short statement for you about the non-pharmacological aspect.
I don't think it's been studied specifically in non-smoking COPD, but I think pulmonary rehabilitation would be just as effective in non-smoking COPD as in COPD, because it's all about improving muscles. And I mean, the main component of pulmonary rehab is improved muscle training so that people can exercise more efficiently. And I don't see any reason why that would be different in non-smoking compared with smoking COPD, because it's really working on their ability to exercise.
Yeah. Thanks, Prof. And along with that, obviously, there's the vaccination data, which has been expanded by Gold this time with 5 vaccines rather than just the pneumococcal and the influenza. So you've got 3 more additions to the vaccination regime that we have as far as non-pharmacological treatment is concerned. So I think we've run out of time. I can see Vinay has appeared. So Prof, really indebted to you, learned a lot, absolute pleasure speaking to you. Thank you for sparing your valuable time. I know how valuable it is. And I know that the audience had a great time listening to you and learning about the new treatment modalities in COPD. And a big thank you to Lupin for having hosted us today on this platform. Over to you.
Well, very, very nice.
Thank you so much. Thanks. So thank you so much, Professor Peter Barnes and Dr. Rajadhar, for this later part of insightful and interesting questions and answers session. I really enjoyed it, and I'm sure that everyone who was connected today, they enjoyed it as well. I would also like to thank all of our viewers on behalf of entire Lupin team and Aspirant Communication team who were eager to hear both stalwarts today and also shared their questions. So thank you so much, everyone. We can go offline.